and my topic today is women's choice on childbirth. And this is important topic, I think, as we are in a kind of a leading maternity care provider in Southeast Asia, which is and more or less our statistics are more or less comparable with developed country with limited resources what we provide. At the same time, we need to pay our attention over the patient satisfaction and the positive experience what a woman received or get during childbirth process. And before that, let me to tell you a few things about our healthcare facilities and the kind of this kind of healthcare that we provide. We are a kind of country of kind of a low resource country. At the same time, our economy is in kind of in a crisis at this moment. On the other hand, we provide free health for most of the Sri Lankans, almost all, though they use it or not. And at the same time, when we think about woman-centered care, can we let our women to decide the mode of delivery? Can we go for on demand or kind of on request elective cesarean section? And there are some issues when we talk about a woman-centered care, and therefore I'll try to make kind of arrangement to which is compatible for our country. Where are the places, where are the occasions, where are the kind of things that we can change to tailor-made kind of things for our people. Why cesarean section rate is going up? When we think about cesarean section rate, the 2-3 decades back, Western people, the trend was to deliver vaginally. When they are, in a party or kind of gathering or something like, women were boasting about the experience what they have received during their childbirth. But now, the trend is changed. The worldwide trend is going for a kind of planned cesarean section. The normal labor is becoming unpopular, and as I said earlier, do our women get right to choose? And there are some organization, independent bodies all over the world. The American College of Obstetricians and Gynecologists, Royal College of Obstetricians and Gynecologists. There are some kind of guidance and kind of sets of rules and kind of codes for women's right. Every woman has the right to safe and respectful maternity care, including the right to make informed choices about her pregnancy and childbirth. These were given by WHO, in fact. They also have the right to choose their place of birth and to have birth companion of their choice. Key rights in childbirth. Just have a look of these. Right to informed consent and refusal, right to respectful and dignified care, right to privacy and confidentiality, right to choose mode of delivery and place of delivery, right to freedom from coercion and abuse. When we see these rights and kind of codes, and even a private sector patient in Sri Lanka, can they perceive or receive all of these rights? I don't think I cannot say yes, the person is going to, is receiving this. But when we talk about the trend and epidemiology of the Sri Lankan trend, we don't have much studies based on this childbirth and cesarean sections and on-demand C-section and things. According to the national database, overall cesarean section rate in Sri Lanka has been rising from 31% in 2014 to 40% in 2018. It is forecasted that more than half of births will occur through cesarean section by year 2025. If you see in teaching hospitals all over the places, cesarean section rate exceeds 50% nowadays. And majority of cesarean sections were carried out for Robson category 5A. When we talk about earlier, indication for cesarean section, the different indications were there, depending on the time of the cesarean section. It's maybe there's a urgent C-section or a kind of emergency cesarean section, routine cesarean section. There are various indications. Other things, indications depend on the presentation, the oblique, live, breech, and things. But those are having limited value when we go for epidemiological studies and kind of assessment all over the country or the globally. Therefore, there's a criteria called Robson classification. It's important to know this classification for people who are getting involved with obstetric gynecology as well as epidemiology and community consultants and everybody basically. There are few criteria, almost 10 criteria. Out of those the criteria 5 is the fifth one is the commonest one. This is for repeat cesarean section for scarred uterus with multiparous woman after 38 weeks. And this study was done by one of my colleagues, Indranil Piyadigama, evaluation of cesarean rate according to Robson classification using newly developed smartphone application in tertiary centers in Sri Lanka. And based on that, we found some facts, and let me to discuss those things with you. Choice of delivery. Cesarean section can be medically indicated or requested by the mother. The medically indicated criteria, the indications are quite important. Whatever the economic state, whatever the facilities available, is it indicated medically, it's a clinically indicated one, we need to proceed with. Definitely it will affect the maternal mortality, morbidity, perinatal mortality, and morbidity. The medical indications for cesarean sections include previous cesarean section, breech presentation, suspected fetal-pelvic disproportionate, and some other medical indications as well. When we think about maternal choices and the maternal attitudes about cesarean section, when it comes to maternal age, the people who are extremities of their age, very young people as well, old people, like to people who reach towards their 40s, they are more prone to request elective cesarean section. And mother's education, what we think, the people who are well educated are more prone to develop vaginally, but not, it is not. The people who are educated are requesting cesarean section more frequently. The choice of medical institution for childbirth. Sometimes the private sector promote cesarean section rather than having vaginal birth. The place of residence, the urban people are more prone to request cesarean section than the people who live in rural areas. And economic status. We think the people who can afford, the affluent people are requesting C-section. And at the same time, when you see the trend across the country, the people who can afford and they more prone to deliver their baby in private sector rather than in government sector, because they have some kind of control over their childbirth and they can request what they want in private sector rather than in government sector. And low parity people, or the nulliparity people, are more prone to request cesarean section. And when it's related to the healthcare system, the doctor's recommendation, sometimes some people, even in some consultants, some obstetricians, they are more prone to promoting cesarean section rather than going for vaginal birth, because when you do a cesarean section, whatever happen, you are safe in modern kind of current situation of the country. If you give a birth, let lady to deliver normally, and if something happen, you are in trouble. Lack of support or availability of resources for vaginal birth, especially the healthcare staff. We don't have adequate staff to provide one-to-one care, and some private sector incentives. And the perceived safety for baby, that's one important thing. And it has been proven again and again, elective cesarean section is safe for the baby, and especially when the suboptimal intrapartum monitoring and care is there. And concern about birth trauma or fetal distress in labor, especially in high-risk pregnancies or after previous pregnancy losses. If mother had a adverse pregnancy outcome during her previous pregnancy, and that woman is requesting for cesarean section, that's a general the natural trend. And by mothers choose cesarean section. That is important. This is where we can address, we can empower our women, we can educate our young generation, and then with limited facilities, we can let them to choose the mode of delivery they want with limited facilities available with us. And psychological factors, the fear of labor pain, that is the most important and the first factor why people request cesarean section. But they don't understand, they get pains, sometimes months and lifelong pain after cesarean section. Fear of vaginal birth and complications, and post-traumatic birth experience, and patient gets some kind of traumatized birth and bad experience during her previous childbirth. Perceived control over timing and process, and social and cultural influences. Preferences for auspicious delivery time and date is a kind of trend in Sri Lanka. When you see a cesarean section in private sector, even 10 to 15% of mothers deliver their child on auspicious time. There's a good study to carry out, even with related to 5-year scholarship exam, how they perform. Is there any kind of significant difference between the people who were born on auspicious time rather than people who born randomly? And obviously all of you were born randomly, I think, the not auspicious time. And influence from family or social circle, and misinformation or biased advice. Lots of people, especially social media, it's a nice trend nowadays. Whenever you get treatment from obstetrician, you put the treatment and everything prescription in social media and ask from others whether it is suitable for you to take or not. And this is a trend and kind of things what happen in Sri Lanka because of unlimited or kind of planned or abnormal use of social media. The problem with high cesarean section, when it comes to cesarean section, and WHO suggested that although cesarean section rate would be 10 to 15, that is a recommended rate of cesarean section to give optimum perinatal care. And but this statement was made roughly 10-15 years back. Now the trend is drastically, significantly changed. 15-20 years back, the childbearing age was roughly the second decade, 20 to 30. It became now third decade. Now it's more towards the latter part of third decade, even in early fourth decade, early 40s. That is because of people are having different kind of attitudes, kind of different priorities in their life, rather than having a family and looking after a child. Therefore, the ones they get pregnant is a well-planned pregnancy. Everybody wants 100%, not the perfect baby. There's no genetically abnormal baby, no congenital malformation, nothing. The baby who should perform very well, like you need to have a better intelligence and everything. Therefore, you don't have any error in obstetric field. That's one thing. Then there's a controversy because we can provide optimum perinatal care or intrapartum care with cesarean section rate of 10 to 15, and heavy burden to the health care system. Doing cesarean section is more expensive than having a normal vaginal birth. Increase the risk of other health problems in both mother and baby. Increase the duration of hospital stay and risk of future pregnancies. At the same time, having repeat cesarean section until that lady completes her family. And ways to encourage vaginal birth, that is the important thing of this particular thing. I just want to highlight these things for our people. Antenatal counseling and evidence-based education. We need to educate them about safe delivery, vaginal birth, all men and women, and from school onward, or A-level class or something, irrespective of their stream of doing their A-level, we need to educate them about childbirth. Psychological support for women with fear with labor, pain, and past traumatic birth experiences. Labor pain management, the epidural, Entonox, TENS, and there's lots of other non-pharmacological methods. Encouraging to have birth companion. This is a kind of trend that I will just want to discuss with you later on. We will discuss, explain the pros and cons on both vaginal delivery and cesarean section. The pain management. When we consider the reason for requesting for a cesarean section, the main reason is pain. The most women experiences and express that is the worst pain they experience during all their lifetime, and it's such a painful event, to be honest. The effective pain relief is not always, that's important. Other thing is, effective pain relief is not always associated with satisfied childbirth experience. So just pain relief won't be, will not give the satisfied customer at the end of the day. Pain perception is different from person to person. When you talk about labor pain, the pharmacological method, non-pharmacological method, pharmacological method, epidural, opioids, and entonox, and non-pharmacological method, massages, relaxing exercises, yoga, water birth, and TENS. And pharmacological, epidural, at the moment, that is the best method for pain relief during labor, but not always satisfying, and the satisfied patient you cannot expect. That is because the less control and numbness and difficulties of moving around the place, and high level of interventions, higher number of instrumental delivery, higher number of cesarean section at the end of the day, is expensive as well. If you go for a private sector for an epidural, you need to pay additional 70,000-80,000 rupees for epidural alone. That is because you need to allocate one medical practitioners to look after the patient. And when you talk about opioids, are it's a kind of cheap method and able woman to cope and relax with the pain, keep the mobility possible, and is quite cheap. But is it enough for the labor pain management? I don't think that is adequate. It is enough for early stage, but latter part of the labor, it won't be. It will not cover the pain adequately. And at the same time, repeated dose can cause respiratory depression, both the mother as well as especially the fetus, and high number of neonatology ICU admissions, and after it affects the breastfeeding as well, and it creates nausea and vomiting. And non-pharmacological methods, pain perception is different. Non-pharmacological methods is referred as mind-body intervention. Relaxation techniques like yoga, music, breathing techniques, and some different techniques of massages, and then use of this we can use alleviate the pain or distract the pain. But do any of those our people who are waiting for childbirth, even in private sector, do they have any kind of knowledge over this pain relief? No, they don't have any kind of preparatory programs, pre-pregnancy counseling regarding pain relief and kind of relaxation exercises. So what are the options available? The combination of pharmacological and non-pharmacological methods will help to relieve pain to great extent and having a better experience during childbirth, and reduce the fear to have a normal vaginal birth. And the next topic area is birth companion. It's a kind of a new trend in Sri Lanka. Birth companion, having someone with mother, and it's a haphazard kind of undirected area in our country at the moment. And as I said earlier, there are few organizations and they give recommendations for their childbirth and guidelines and like this. And the birth companion, who can be the birth companion? The relative, a friend, husband. In Sri Lanka or other country, it would be partner, the boyfriend, and community worker. Ideally, the birth attendant, traditional birth attendant called doula. And husband as a birth companion. In private sector, you let husband to stay with wife, and husband doesn't know anything about labor. At least he hasn't watched even a film or a kind of a documentary or a kind of YouTube video related to birth, and it's a kind of the proceedings what will take place during labor. And most women happy to be with their partner and considered as a bonding experience with the family, with the child, and with kind of wife as well. But the adverse part of it, some scared, and scared, he is afraid and of scared than the woman herself, therefore stress out when partner is in pain. She's the person who suggests go for a cesarean section immediately. Doctor, why don't you go and do a cesarean section, get the baby out? And that is not the birth companion's role to carry out. And when you talk about labor companion, it has been proven again and again with varieties of researchers, shorten the labor time and increase the rate of vaginal births, decrease the cesarean section and intrapartum analgesics, increase the satisfaction with childbirth experience, less fear and distress during labor, and high ABGA score at 5 minutes. That is quite impressive, isn't it? And labor companion, further it gives the bridge, the communication gap. The woman may be in pain, not in sound mind. She may not be able to express herself, but birth companion is there. He or she is the person who talk on behalf of the patient, advocate the speak on behalf of. Non-pharmacological pain relief like massages, rubbing, and all those kind of things he or she can carry out if he is aware of that particular procedures, and emotional support as well. And the physically presence of birth companion reduce the mistreatment as well. It has been proven in Western studies. And who is the ideal labor companion? In Sri Lankan settings, doula, we don't have the professional birth companions. The husband is not the ideal person. And in Sri Lankan settings, the ideal person would be a woman who is not close relatives to the particular person and has delivered a baby vaginally, at least one baby, who has, the birth companion has delivered a baby. Then she will be able to give a kind of moral support, kind of share her experience during labor and relieve her distress and take her through this difficult journey until the end. It should be a non-medical profession. And what are the limitations that we cannot provide, and if you provide, what are the things that we need to adjust? And privacy. We do have labor wards, labor rooms rather than labor ward. There's a hall where few people stay and deliver in different stages of their labor process. Lack of resources. And the cultural barrier is a multicultural settings. The one person may not be tolerating the another person is having outsider with the common place. And attitudes of the staff is quite important. In Sri Lankan settings, the changing something is not that easy, because the next day midwives and the theater staff, the labor room staff may be on the road making kind of protest because the people who is outside going to take over their duties and they will be jobless another couple of months time. And that is, those attitudes are quite important. And possible interference in activities in labor ward, for example, is a PPH or something like that. With Sri Lankan mind settings and things, the person who is coming may be getting videos, getting posts and posting those in social media. Those attitudes are quite difficult. Quite difficult to change, as well as those are the limitations where we face difficulties in accommodating birth attendant in our settings. When we think about Sri Lankan settings, the letting persons to decide the mode of delivery that she or them wants, and these are the things we need to pay our attention over. The change the vision and the giving kind of adequate education about labor and the cesarean section and what are the consequences. Alleviate the fear of labor and good pain relief, allowing them to have a birth attendant and building that culture gradually, but in a professional way, and women-centered care, and researchers teaching and training, and at the end of the day leading some kind of customized settings for the Sri Lankan population. And that's it regarding this small discussion. And thank you.